All right. Good afternoon, everyone. Thank you for joining us today. This is the October Climate and Health Lecture Series from St. Luke's Sustainability Program and the Idaho Clinicians for Climate and Health. We have a few more lectures this fall/winter season, including in November, a lecture on plastics and human health, featuring speakers from the University of New Mexico and UCSF. And then in December, we'll have our capstone um, lecture from Bill McKibben, talking about his career spent in climate and health. Our speaker today is Anna Goldman. Dr. Goldman is a primary care physician, researcher, and the medical director of climate and sustainability at Boston Medical Health System. In October 2023, she co-founded the Clean Power Prescription, a program to bring solar energy to patients who report difficulty affording utility payments. This was created in collaboration with Bob Biggio, BNCHS's Senior Vice President of Sustainability and Real Estate. This program uses energy generated by a solar array at Boston Medical Center to reduce the cost of utility bills for patients enrolled in WellSense complex care management. She is currently funded by the National Institute of Mental Health to study the impacts of a novel healthcare payment model, accountable healthcare organizations on adults living with serious mental illness. In 2022, she served as an advisor to Mayor Michelle Wu's administration on climate-friendly food procurement for hospitals and universities. She is a primary care provider in the General Internal Medicine Clinic at Boston Medical Center. And I'm very excited to introduce Dr. Anna Goldman. Take it away.
Thank you so much. And it's really wonderful to be here. I'm going to share my screen. So yes, I am the Medical Director of Climate and Sustainability at Boston Medical Center Health System. And it is a new position. I've been in this role for less than a year, but it's really exciting. And this position has not existed before this year. And it's been a really exciting journey. And the way that I got into it was through that Clean Power Prescription program that I will speak more about shortly. Okay, so a little bit about Boston Medical Center. Actually, I'm just gonna give you some overview about who we are. We are the largest safety net hospital in New England. We actually Boston City Hospital, which was the original name of our hospital before we merged with a BU University Hospital, was the first city hospital in the US. So we have always focused on serving the underserved since the very beginning of our creation. We now are as I mentioned, the largest safety net in New England, also the largest trauma center. We do about 1 million patients visits per year. 70% of our patients are people of color. 70% have public insurance. And we have recently welcomed 2 new health centers into our health system, which is a first for us. We've been kind of a one hospital system for many, many years. Some of you may have heard about the Steward healthcare crisis, in which a for-profit system went belly up, had hospitals across the US. In Massachusetts, there were 8 affected hospitals, and we've taken on 2 of them. So now we have grown a lot in a few short weeks. We just took them in on October 1st. So why do we do the sustainability work that we do, and why have we invested so much in it? Well, it's because of who we serve. So our vision, our overarching vision, is to make Boston the healthiest urban population in the world. That's our kind of aspirational goal. And our patients are coming from communities that have been affected by environmental pollution historically and are now more vulnerable to climate change. And so we felt that it was incumbent upon us, if we were going to serve our mission, to invest in sustainability. This is through both increasing our efficiency as an organization, which lowers our costs, and through cleaning up the impact of our operations on the environment, which lowers the kind of toxic impacts on our patients. So by increasing efficiency and also by investing in lower cost renewable energy, we've actually been able to create savings for our patient care. And I will be sharing some of those numbers with you. So we've been able to reinvest those funds in patient care, which is our primary mission. And we're also committed to bringing our patients into the conversation, helping to create a more just transition as our economy transitions towards green energy. So we are proud to share that we have reduced our Scope 1 and Scope 2 emissions over 90% since 2011. So we have this, you see two lines here. We have market-based emissions, which is the yellow line, and then the location-based emissions, they diverged because we invested in virtual power plant agreement, which I'll talk about in a minute. But even our place-based emissions, we have reduced them by 51% as of 2022, and met that Health and Human Services goal of emissions reduction by 50%. And I'll talk a little bit more about how we've done it. The biggest aspect of our work has been our campus redesign. So this was a massive project that we started in 2012. Bob Biggio, who was mentioned at the beginning, who's now our Chief Sustainability Officer, went to our CEO and said, if we want to remain financially viable, we need to rethink our campus and kind of rethink the fixed costs that we have on our campus. He pointed out that there was very inefficient use of space. We were too big, actually. And so that's you see a lot of hospitals growing and kind of supersizing. His pitch was to shrink the campus. It was a $350 million project that he pitched, which would shrink the campus by 8%, but also redesign buildings and make them more efficient, update HVAC and electricity systems, update insulation, and generally save on all those kind of fixed costs that people see as kind of an immovable cost for hospitals. And so it was a 10-year project. It was financed through green bonds. So we were one of the first hospitals, along with Kaiser, to issue green bonds, and those are a fundraising mechanism that are specifically designed towards sustainability projects. They have to be certified, and there was such strong demand for these bonds that we got a very advantageous interest rate that saved us millions of dollars. We were able to raise the funds and invest in this long-term project. And this is some of the results of that project. So you can see that the line that was similar to the previous slide, our total emissions is this bottom line here. Over the same period, from 2011 to 2022, we actually increased patient volume by 30% in that time. So we shrunk the campus. Here, this is the square footage by 8%, but increased patient volume by 30%. We also decreased our electricity usage, here this yellow line, by 29%, and our steam consumption by 48%. And that was all through shrinking the physical footprint and also updating our systems. And this is a specific slide on energy costs. So we just for electricity, we're projecting $150 million savings because of increases in efficiency and decreased need for energy because of a smaller space. So this is a 30-year projection. So how did we do it? This is one small example. This is a combined outpatient clinic and sleep study space. So we have Murphy beds in the walls of the outpatient clinic so that we didn't have to build an entirely separate suite to be our sleep study center. And just by kind of reusing the space, we were able to shrink the footprint, decrease our square footage, also avoid the cost of building and avoid the carbon emissions associated with having the need to build an entirely separate suite. And I've actually practiced in these rooms, and patients, they see that it's a large room, but other than that, have no idea that people are going to be coming in and using it as a sleep center in the evening. Another cornerstone of our work and our in our efforts to reduce emissions is our Brockton Behavioral Health Center, which opened in October of 2022, so it's now 2 years old. This is the first net zero behavioral health center in the country. It is dedicated to serving an environmental justice community, increasing the number of beds for psychiatric and substance use disorder treatment. We have 80 beds. It was a repurposed nursing home from the 1970s. It was sitting vacant for many years in the community. BMC bought it and put in, with the assistance of a generous anonymous donor, put in geothermal wells, solar panels on the roof and over the parking lot, and also installed battery backup for nighttime use of the to capture that solar energy at night, and a highly insulated building envelope, continuously insulated envelope that makes the building much more energy efficient than it used to be. And it is operating on a net zero basis now, and is another way that we have reduced our carbon emissions drastically as of 2022. Okay, in terms of the market-based emissions, this is the virtual power purchase agreement that I mentioned. So we have a solar farm called Summit Farms in North Carolina near the Virginia border. We went into this arrangement as an anchor tenant, which means that we were offering the financing so that this project could get built. It would not have been built without, they need people who are committed to purchasing the energy once the project is built. So we partnered with MIT and Post Office Square Redevelopment Corporation, which is a large developer in Boston, and signed a contract to purchase energy over 25 years from this solar farm. Now, as a virtual power purchase agreement, it is not the electrons themselves that we are receiving, but rather the renewable energy credits that helps with our market-based emissions accounting. So we have 16 megawatts of this farm that are supporting our carbon emissions offsets. And we're proud to be helping the grid transition towards renewable energy in this kind of innovative way that is that allows for the purchase of larger amounts of solar energy that is less expensive, because obviously the land is less expensive down in North Carolina than it is to develop this kind of thing up in Boston, although we are working on that as well, to be continued. We also installed a cogeneration power plant in 2017. So this is a natural gas fired power plant. So we see this as a kind of an interim step in our climate journey. Obviously, the goal is to eventually completely transition away from any fossil fuel based energy. But as of now, this is a highly efficient power plant that allows us to operate with resilience in a way that some of the other power sources do not have in terms of advantage. So this is a 70% efficient power plant instead of a regular natural gas-fired plant, which is 40%. And that's because it is generating electricity and then capturing the heat that is lost in that process and using it to heat our buildings. So the increased efficiency provides savings for us, about $1.5 million of operating savings. It also allows us to operate in islanding mode and produce enough electricity to run our inpatient units indefinitely when we have, in situations of grid failure, as long as we have a supply of natural gas. So that is a key aspect of our resilience planning. And there wasn't, when we were looking at this project, there wasn't an alternative that was a fossil fuel free project that would allow that level of resilience to power our entire inpatient unit. So this is, again, what we're seeing as an interim step as we make that transition. Okay, so now some of our more patient-facing work to bring patients into the fight against climate change and the energy transition. So since 2017, we have been operating a farm on top of our power plant building. You can see it here. It's in milk crates, and it is a highly productive farm. It's producing 5,000 to 6,000 pounds of food every growing season. And it supplies our preventive food pantry, which is, I can refer patients as a primary care doctor. I can refer patients to our food pantry. It's been operating for more than 20 years. And as of 2017, they started distributing these hyperlocal vegetables that we're actually growing right on campus. We also supply the cafeteria, the inpatient unit foods, and our farmers market. And then this past spring, we opened a second farm that's called New Market Farm, which triples our growing space and is an even more sort of highly engineered and productive farm that is, again, supplying those same outlets with fresh produce, as well as a local shelter for victims of domestic violence. And this farm specializes in growing culturally tailored crops. So we have specific immigrant populations that we are growing crops to sort of meet their needs and desires. So we're growing callaloo for the Haitian community and bok choy for the East Asian community, and then aji dulce peppers for our Portuguese community. So it's been a very successful growing season. We've produced about 10,000 pounds of food just from this farm, and it's really increased our impact. We also have two beehives to help with pollination in the area, because this is really it's an area that is it's a food desert. It's kind of a desert. It's a there's very little vegetation or green spaces in the neighborhood where this is, and so this is kind of an oasis for pollinators to stop in and allow them to survive in this neighborhood. I also want to point out in terms of the benefits of these rooftop farms, they do help cool the building underneath it. So this is one of our administrative buildings. And actually in this top right-hand corner, you can see there's kind of a canopy in the back of that image, that those are solar panels that are co-located with this farm. And I'll talk more about those in a moment. But the farm itself is cooling the building. And it's also capturing runoff, so rain runoff that would normally go straight into the storm drains. Okay, so now on to the Clean Power Prescription Program. So since 2017, we at BMC have been screening for health-related social needs. I know more and more hospitals are doing this, and we were an early adopter of that practice. And I'm sure many of you are familiar. Oops, excuse me. Let's see. Can you still see my screen? For some reason, it just kicked me off. Okay.
Yes, we can.
Yeah. Okay, great.
Yeah, we can.
Okay, good. So by health-related social needs, I'm sure many of you are familiar, but it is things like housing insecurity, food insecurity, difficulty accessing transportation, affording medications. And we had been screening, this is a screenshot of part of that screening down in the lower right corner. And we had been asking patients if they could afford utility patients since the beginning. When we started the screening, it started in our pediatrics department, then rolled out to internal medicine and then the emergency department. And so I was able to obtain data on this issue when I became interested. And I became interested in part because providers like myself can write letters to prevent the shutoff of someone's utility. So if they've received a disconnection notice from the utility, they can come to a provider and say, I have a chronic health condition. Can you please provide me with protection from shutoff? And that is a Massachusetts state regulation that utilities will respect that letter. And so I'd been writing those for patients. And I was seeing more and more patients with this issue, especially. So there was a moratorium on shutoffs during the pandemic. And then as we came out of that emergency period, we were seeing more and more patients struggling with the cost of energy. And Massachusetts is one of the most expensive energy markets in the country for all kinds of reasons. So the average family spends about 3% on home energy costs, but the average low-income family is spending around 10% of their income, which is considered a high energy burden. And some neighborhoods, it's up to 30% of income is spent on utilities. So, and so why are we screening for this? Why is there a connection between energy and health? So there's the obvious connection, which is medical devices that require energy. One of them, maybe nebulizers, CPAP, there's home dialysis, there's hospital beds. But energy is a core need for people even who don't have medical devices. In the summer, we need energy in order to stay cool. I have a number of patients who report having air conditioners but not using them because they can't afford the cost of their electric bills when they are regularly turning them on. Refrigerators required for preserving fruits and vegetables, fresh foods. When someone has a utility shut off, they often lose an entire fridge worth of food, which can be incredibly expensive and also detrimental to their long-term health. They also may need to keep medications in the fridge. And in general, if you can't, keep your lights on, it's hard to do your homework. It's hard to read your medication bottles. It's just a really core aspect of well-being. And many people consider the utilities as kind of a foundational part of their expenses. And so some people, and we see this in survey data, when they can't afford utilities or when they're too expensive, they are paying them before they're buying things like food and medicine. So it's a burden that affects health in a number of ways, both through energy insecurity, but also through substitution of costs by covering utilities, not buying other things. Okay, so I was observing all of this in my patients, having these struggles, having to choose between utility payments and food, and requesting these letters from me. And I thought to myself, I just joined a community solar array myself for my own home as I got more and more interested in climate advocacy and was doing work on that. And then I interacted with a group in 2021 through doing climate advocacy that was putting cooperatively owned solar arrays on the roofs of community buildings. And the idea is that low-income families can connect with this group and actually be given a share of a solar array so that they are part owners of the solar array, in addition to, in some models, benefiting from the energy itself. And I love this idea because it gets at a core idea at BMC. We really see health and wealth as inextricably linked. So it's creating a source of passive income for people. It's bringing them into the energy transition, which many patients at Boston Medical Center just can't even begin to access. And then it's also helping with those utility costs. So I loved this idea. I brought it to our chief, our vice president of mission, Thea James, and our chief of real estate, Bob Biggio, and pitched this idea that we would actually help our patients with solar energy and that they could be part owners. In the end, they loved the idea of helping our patients for a number of reasons. We could not lease roof space to an outside group because BMC needs to sort of be able to control its own real estate, which I've now understood a little better. But it turned out that BMC was already in the process of constructing the second solar array on our campus. The first one was at Brockton Behavioral Health Center, and the second one is on an administrative building that shares space with that second farm. And so Bob and I co-founded Clean Power Prescription. You can see a picture of us here on the right. Bob standing in the middle, and our CEO, Alistair Bell, is on the far right. So we launched last October. We are running it through our WellSense complex care management plan. So WellSense is our associated health plan. I didn't mention it at the beginning, but it is a really crucial part of our our health system. It is the largest Medicaid managed care organization in the state. So we cover about 750,000 members, all of whom have Mass Health, which is our state's Medicaid program. And we did it we decided to run this program through WellSense for a number of reasons. One is it's an intensive, it has this intensive complex care management program. So the idea is if someone is utilizing more care, so more time in the emergency department, more visits to the inpatient unit, then we think, we think that better optimization could lead to lower utilization. We try to intensively address health-related social needs in hopes that it improves their overall health outcomes. So they have a community health worker model where they have a nurse paired with a community health worker, and they screen for health-related social needs, and then they work to address them. So because they had that manpower, because they were already in this space of trying to address health-related social needs, they were willing to partner with us. It also helped with legal concerns around the idea of giving out power, giving out credits could appear as an inducement for patients to basically attract patients to our hospital. To avoid that appearance, this has become a benefit of our health plan. Okay, so we have this, so we're using this 356 kilowatt solar array. The way it works is it's producing electricity. It's a front of the meter system, meaning it's not supplying the building that it's on top of. It is gathering the power, running it through a meter, which measures how much power we are producing, and then sending it out to the local power grid. So the actual electrons are not going to patients. They're going to whatever end user needs electricity at that moment that's nearby BMC. But instead what's happening is the meter, which is owned by our partnering utility, which is Eversource, is counting how much we produce and then putting a credit onto our bill. So they're essentially purchasing power from us. We're the supplier, they are the buyer, and we have a credit on our account for the amount that we produced. And then we can then direct the utility to transfer a portion of that credit directly to our patients' accounts. So they get a credit directly on their bill. Enrolled households will get $600, approximately $600 over the course of 12 months. So we decided for this, this is a pilot phase of this program, since this has not been done before, and we wanted to, experiment with it. So this could change over time, but right now it's a 12-month program, and we chose $50 a month as a meaningful amount that covers between about a half to a third of the average household's electricity bill. And we thought it was a meaningful amount that would allow us to serve not a tiny number of patients. So our pilot enrollment goal is around 80 to 100 households. And we wanted to enroll people only for 12 months because we wanted to be able to spread the benefit beyond just those that first cohort of families, which is, we know that people who have energy insecurity, it tends to be a longer term problem. So I'll talk about how we address that in a moment. But in order to get into the program, once they're in that complex care management program, they can enroll in WellSense if they are experiencing difficulty affording their utility payments. So that's just a self-reported measure. They also have to live in the same utility load zone as our solar array is located, because right now we are not allowed to transfer credits across load zones. So there's about 30 cities and towns, including the city of Boston, that is in that zone. So there's a large area that we're working with. And then they also have to have Eversource as their electricity provider, which is the largest utility providing electricity in the state. So that's been also not such a limiting factor, which is good. Okay. So because people do graduate from the program, we wanted to include an intervention to improve long-term energy affordability for folks. So we've partnered with a local community group called Action for Boston Community Development, which is a nonprofit. It's been around for over 50 years, and they have an energy division. And when they are connected to our patients, they first help patients with the affordability piece by enrolling them in programs that target utility affordability. So LIHEAP, which is a heating fuel assistance program to reduce the cost of heating fuel. And then also enrolling them in the discount electric rate. In Massachusetts, there's a discount rate which anyone who has Medicaid is entitled to access. Unfortunately, many of our patients qualify but are not enrolled in the discount rate, so we correct that. And then we also have a statewide program called Mass Save, which is a state-funded program to improve home energy efficiency. And people who have Mass Health and other means-tested benefits like SNAP can access that program free of charge, which is an incredible resource with very poor uptake. So it's available to the community, but most people are not using it. So this is a way to connect people with that service. So people actually, so once they're connected, they will have an auditor come to their home and do a full energy efficiency audit, and then provide upgrades that can improve the efficiency of the home, make it improve the air quality through better ventilation and weatherization, and also in some cases electrify. So they'll get more efficient electric appliances. If they have delivered fuel, so propane or oil, they can also get a free air source heat pump installed. Right now, they're not replacing natural gas furnaces because it will increase the cost of their electricity bill so much that it's cost prohibitive. And then we're also working with patients to deal with an issue that we have in Massachusetts called, we have an unregulated or a deregulated electricity market. It's one of the reasons why I mentioned Massachusetts is one of the most expensive electricity markets in the country. One of the reasons is because we've been deregulated and we have a group of predatory companies that have been allowed to come in, and they tend to market directly door to door and target low-income neighborhoods. So many of our patients who we've enrolled in Clean Power Prescription have been enrolled in these kind of scam companies. They say they're providing green energy. In fact, they are not. It's false advertising, and they put a significant markup on the bill. So this is another key problem that is causing our patients to suffer with utility insecurity. So we're helping patients get into better contracts and educating them about how to avoid these scams in the future. We're also engaged in advocacy to get this outlawed, and we were very close in our last legislative session, but ended up losing due to intense lobbying by the industry. Okay, so just a little bit about our values and why we're investing in this project. So as I mentioned, primarily we are seeing this as an anti-poverty program. $600 can be a significant subsidy for families. That money can be used for other necessities like food, medicine. We are doing surveys of patients who when they enroll in the program, and then upon exiting the program, to ascertain whether $50 a month was a meaningful amount for people, or the $600 over the course of the year was a meaningful amount, and to what degree it alleviated financial stress, to what degree they were able to access other necessities through this program. We also believe in this program because it's a way to talk with patients about renewable energy, about climate change, and to engage them in this energy transition, which again, really, it's not. It affects our patients the most, and yet they have the least bandwidth and ability to kind of access these new technologies that can lower costs and also clean up. Lastly, I meant to include a slide. One of the most exciting things about this program is that it leverages Inflation Reduction Act funds. So let me see if it's not there. Okay. So we have I'd like to include a slide on this. One of the reasons this program was able to exist was because we happened to have this conversation right as the Inflation Reduction Act was passing and was being implemented. Many of you are hopefully familiar with this. It's the largest and most important policy package to address climate change in the history of our country. And it includes several provisions that subsidize renewable energy, and specifically subsidize it for environmental justice. And the way that it works is it's a set of stackable credits. one of the exciting things that it does is allow nonprofits to access these tax credits, which previously, because we don't have tax liability, federal income tax liability, we could not have accessed them. They added a provision in the Inflation Reduction Act that would allow what they call elective pay or direct pay, which allows nonprofits and also state and municipal governments to access these credits directly as just a payment from the IRS instead of basically being left out of this as a mechanism for incentivizing construction. So our solar array, we actually expect 60% of the total cost to be covered by the Inflation Reduction Act, and that's 30% is a base credit. We're getting another 10% because we are building on a historical brownfield. Much of Boston is actually historically a brownfield because of toxic fill that was used to fill in kind of marshy land. So we get that, and then there's another 20% bonus because we are sharing this power, or we are sending the power to low income communities. So that's called the Low Income Communities Bonus Credit. And that's the environmental justice piece. There's actually four different environmental justice credits that are available for renewable energy projects that are also trying to address environmental justice. And this is the largest one of those credits. We applied for it. We were in the first cohort of organizations to apply, and were approved last January to receive that credit. And we actually haven't received the payment yet because we have to file in 2025 for our 2024. Our taxes from 2024 is when we will actually see the money, but we are expecting 60% to be covered. And so that really allowed us to make a business case for doing this project, and it's what was it was a pivotal piece in allowing it to move forward. Okay, so the future goals for this, and then I'll stop and let people ask some questions. This project, so we are trying to build more solar now on our campus through fundraising efforts and access more of those IRA dollars. We also are trying to develop external partnerships. So one of the neat things about this program is that it can be scaled without us even hosting the solar. So we have had conversations with a number of outside organizations that are interested in building their own solar arrays and putting aside a portion of those panels for our patients, and they would just basically give us permission to make that transfer from their account to our patients' accounts. And all we need to do it is kind of their permission plus our patients' account numbers. And it's an easy way to do it, and it's an easy way for people to support that energy transition and address environmental justice without a huge effort on their part, because we do the administrative work. And so we have interest. We haven't solidified any of those partnerships yet, but that's what we're hoping to do. We've also had conversations with many other health systems that are interested in models like this. This is one of them today. And then we're still hoping to build a cooperatively owned version of this that our patients can benefit from. We are in conversations with a local community group, with the group that is building those cooperatively owned solar arrays. So the first one of those is being built on a food co-op in Dorchester, which is part of our catchment area, and we are trying to help them secure a second site. And that one's very near and dear to my heart. So I'm hoping we can achieve that. Okay, and I'll just end with this slide, which is the point of which is that sustainability is really not a side project for us. We're working to incorporate it into every decision we make and every undertaking that we do, to be thinking about sustainability and environmental justice as part of the calculus, and really as a smart business practice, because those upfront investments do generate long-term savings for ourselves and for our patients. So I will stop there and open it up for questions. I think there are some in the chat.
Thank you so much, Dr. Goldman. That was outstanding. And what an amazing history of sustainability leadership Boston Medical has shown. I am just blown away every time I hear stories coming out of BMC about the innovative work you guys are doing. Um, One question I have is, I know that part of the IRA kicker for the environmental justice 40 funding for the solar project was that you had to give away 51% of the energy for it to reach that threshold. Are you keeping any of the power that's generated by your rooftop solar to power your own buildings, or is all of BMC being powered by that virtual power purchase agreement?
Yeah, so so it's really our place-based emissions that we're working on because the VPPA has covered all of our electricity needs. We do have some scope 1 emissions that are like anesthetic gases and a few that we have about 9% still to go in terms of market-based emissions. But no, we are giving this power entirely to patients because it's been such a successful program. It's really kind of solidified and advanced our mission because of it's been a morale booster for our staff, and patients also are really excited. It's a bit of a hard thing when people understand that they actually have to be in WellSense and be in the complex care management program. It's not just all comers that can access this. But we do hope to, we have visions of expanding the program so that more people can be in it through connecting people to community solar contracts that would be longer term contracts, by facilitating a relationship with developers that are not just because we're giving away the power, so we can't do that for all of our patients. But connecting them with other organizations that can offer them a 20 or 30-year subscription is another future goal that we have, that we could actually scale this to more patients.
Great. Next question. First of all, thank you so much. And second, who owns the actual solar panels for the community solar system? Does Boston Medical Center own them, or is it the Eversource utility company? And do you have plans to utilize incoming EPA Solar for All funds to develop more community solar projects for low-income households?
Okay, so we own the solar. Originally, it was designed to be a power purchase agreement, so we weren't going to own it. We were just gonna buy the power. But because the way that the Inflation Reduction Act credits work, there's a limited number of credits for that environmental justice credit, that low income communities bonus credit. And you get bumped to a category where it's easier to get the credit, to actually get that allocation, which means you get selected for the number of kilowatt hours, or excuse me, kilowatts that your facility, your nameplate capacity, like you can get that allocation more readily if you are a nonprofit and you're located in an environmental justice neighborhood. So we met both of those criteria, whereas the developer, the original developer, did not. So it made economic sense for us to actually purchase it from the developer, and we took on we took a financial risk for that because we're holding some of that debt while we are waiting for the IRA funds to come through next year. But and then in terms of the Solar for All, so we know that Massachusetts has been approved for, I think, $146 million of Solar for All funds. It's not 100% clear how those will be divvied up. If we can get the access to a portion of those funds, we absolutely would use it to expand this program. We have identified at least 5 other sites on our campus where we could expand this program, and are actively seeking funds to do that work. We are also working on we have 13 community health centers and a network of community health centers that's affiliated with BMC, and we are working with them to invest in a solar farm that would supply their energy needs in Massachusetts. Yeah. So that was
Have
all
you been,
those funds. Yeah.
yeah, have you been able to document, operational cost reductions by giving this power away as of yet? I mean, it seems like the cheapest healthcare is that which we don't provide because our patients are healthy enough not to need it, both from a cost and a carbon standpoint. We know that no healthcare is the lowest carbon healthcare to provide because our patients are just healthy enough not to need it. So I'm wondering if, BMC is making this upfront investment, and even though IRA is offsetting a lot of it, you're still making some investment that's basically going to a patient financial benefit. But it seems like in the end, this is going to decrease BMC operational costs because you're going to see patients needing less healthcare, especially patients that are sort of low reimbursement, low income populations. Are you tracking that, or have you seen any of that as of yet?
So we're not seeing it as of yet. We had a number of delays in actually enrolling people because first was sort of getting the Inflation Reduction Act paperwork, and you actually can't, for anyone who's thinking of applying, the facility can't be in operation until you're actually approved for the credit. So we delayed for that reason. Then we were approved, and then there was a whole set of delays related to interconnection, which is another challenging part of connecting to the grid, basically, a part of this. So we finally turned it on over the summer and then transferred our first credits. Then there was hold up on the utility end and transferring the credits and accounts that were shut down, and so it was a whole big ironing out of many challenges. So we've transferred the first credits this past September. So it's really, really actually very new. It took longer than anyone anticipated to actually get it up and running off the ground. We're thrilled that it actually is now. So it's too early to see that kind of signal. I would also say that with a lot of these programs, even something as fundamental as housing, like housing, you do see reductions in utilization when people are stably housed. But some of these other interventions, and sometimes even with housing, like you don't see, or giving people health insurance through the Oregon health insurance experiment, like you don't always see the signal just as you might think, because for whatever reason, because there's many different health related social needs that determine someone's health outcomes and utilization, or because when they're feeling better they actually come in, or there's all kinds of reasons why it may not actually reduce utilization. And to my mind, it doesn't mean we shouldn't do it. It's still, if patients are appreciating it, which is a big part of what we're evaluating. I mean, I can definitely follow their utilization. We have that data, but the survey is more focused on their kind of financial well-being and financial stress, and whether they're needing to take on debt, whether they're needing to sort of make choices between essential needs. That's where the focus of the survey is. We will also do we'll do qualitative interviews with patients to kind of pick up themes that we might not have noticed, and we will ask about that too.
Question, is home ownership required for patient participation? And if not, how do you manage with renters, especially with regards to the additional ABCD benefits?
Yeah, so no, it is, you just need to be paying your own electric bill in order to access this, because so if you're a renter with an account, and it doesn't even have to be the patient. For example, we have pediatric patients in the program and it's their parents' account. One thing that we are using here, it worked well for us to be applying for the IRA credit because we can verify people's Medicaid status. Medicaid is a categorical eligibility to count someone as a low income household from the standpoint of the IRA. So, but it counts even if it's just anyone in the household, or at least that's been our interpretation of the law. So if anyone in the household is in Medicaid and someone in the household is paying their electric bill, then we can take that. We basically collect the bill or an image of the bill from the patient's household, and then we can submit it to the utility, and they can use it. Now, in terms of the ABCD benefits, yes, renters can use those as well. There is even poor uptake of the home energy efficiency types of benefits through Mass Save when someone is a renter. We're actually at work on another program that is a partnership with the Boston Housing Authority and is aimed at Section 8 voucher holders. So those are, that's the largest part of the Housing Authority's program, is vouchers that pay people's rent. So they're not actually living in in BHA owned housing or Housing Authority housing. They're renting on the private market using a voucher. And those households have been incredibly hard to target with Mass Save because many of the landlords are not interested in letting people in, even though it's free of charge, because the requirement is just that the person themselves counts as low income, which if they have Mass Health or Medicaid, they do, or SNAP benefits. And they can access those services, but the landlords are often a barrier. So Boston Housing Authority is actually going to offer a boost in the rent to the landlords that accept the Mass Save benefits and upgrades to the housing so that we can move towards our energy efficiency and decarbonization goals. And BMC will act as basically a referral network for that program. So we will be framing home energy efficiency as a health intervention that we can provide to patients, especially patients with respiratory illness or pediatric patients, because it does improve air quality. Okay. That was a long answer.
No, it's all great though. I mean, you know, I until a year or two ago, I never would have thought of clean energy as a health benefit that you need to prescribe, but it totally makes sense the more you hear and learn about it. Um, from Dr. Wepner, who I think you may know. Thank you for an amazing presentation. It's interesting to hear BMC is shrinking its physical plant footprint. Our local systems are definitely increasing our footprints. Any thoughts about how programs like Hospital at Home might allow healthcare systems to downsize?
Yeah, so that, I mean, okay, so I'll first put in a little plug. So BMC, you need a smart engineer to think through your physical plant. That's certainly not my area, but we have that's been a real asset for BMC, and that's what Bob his main contribution has been just very smart thinking about efficient use of space. And BMC recently co-founded a joint venture with a private company to create a new company called Oakwell, which is a firm that embeds consultants into sustainability teams at healthcare institutions to optimize their physical footprint and increase the sustainability of their operations and kind of export that ability to grow while shrinking, I guess is one way to put it, to other institutions. Because yes, exactly, Bill, like many hospitals are growing right now. Every square foot of hospital floor space is incredibly energy use intensive, very, very high EUI energy use intensity. Seconded only actually by, I think, food service because of the refrigeration, like grocery stores. So it's so shrinking the footprint is kind of the core thing that you can do. And I think individual advice on how to do that is tailored to each institution, but it's something worth thinking about. The one other thing I'll say about that is that we've been doing some research on the impact of guidelines that were put in place in 2006. There's a group called the Facility Guidelines Institute that creates guidelines for hospitals, for hospital construction and design. And in 2006, they added to their guidelines that hospital inpatient rooms should all be single bedrooms. And this was based on data on patient preference, privacy, and then infection control, which does make sense. And I will also say that the Federal Guidelines Institute, they're not a government body, they're a private body, but many public health commissions do adopt their guidelines. More than 2/3 of states have. And the impact on hospital footprint is unknown and on carbon emissions of this policy. And so we think it's worth thinking about that as a policy, whether, from an emissions standpoint, the benefits outweigh the risks. In fact, the data on infection control has not been as robust as one might think. And so thinking through that as, in terms of the cost benefits around emissions is another area in which we're interested in exploring.
Yeah, I mean, I think we see that a lot with other sustainable initiatives in healthcare, that there are these questionable infection prevention studies that obstruct progress in some other sustainable initiatives. And as with St. Luke's, and I'm sure with BMC, the true north is outstanding patient care and patient health and safety. So we would never do something to compromise the quality or safety of patient care in the name of sustainability. But I think we have to revisit some of these infection prevention recommendations that are old and based on poor data at best.
Yeah,
Um,
yeah, definitely. Yeah, so that's
but I love that you cited an example in your talk of not combining patients in the same room and doing that sleep study clinic space, because that is definitely a driver we see in our expansion, is maintaining private patient rooms is a huge request from our patient community. I want to try to combine a few questions and just try to get through a few more things in the last few minutes that we've got. Um, a question I had, I'm sorry, I've got them in a couple different places. So I'm trying to shuffle back and forth. Um, as a physician, we sometimes are left feeling isolated from healthcare administrators. It seems you were able to connect to the appropriate decision makers who could help you make this really innovative program happen. How did you get access to these leaders you partnered with at Boston Medical Center?
Yeah, so I was really surprised by the reception I got, and I will say that um BMC is unique. Bob, who I keep mentioning, our chief sustainability officer, had not come to sustainability kind of as a passionate environmentalist, actually. Like he came in from a cost savings perspective, but then really saw the light with how much he could do through both cost savings and sustainability, and started and kind of came in through the back door of being a believer in the importance of this. And so he was really already, by the point I met him, he was all in on the environmental benefits and understanding the environmental justice aspects of things. And then BMC has always been a mission-driven place and always really centered that idea of wealth generation as a key kind of aspect of health generation. So I first went to the vice president of mission, Thea James, who's kind of driving the ship in terms of our mission, and made the pitch, and she really got it. And then I was expecting to sort of need her to push Bob, but then Bob immediately got it. So I mean, it's not really a replicable model. For other people, it was just good luck that I had support at the top. And then Bob had done some advocacy around the Inflation Reduction Act before it was passed. He had been in DC with Healthcare Without Harm and actually spoken to lawmakers about what would allow BMC to engage in this kind of work. And it was specifically, especially around the direct pay, which allows us to access tax credits without tax liability. And they did include that. And so he was excited to kind of try it out and be a guinea pig, because he had been engaged in the advocacy process that led to it.
And just one last quick question I'll try to cram in, combining a few of these financial questions that we've got that I think are all really relevant. Have you been able to track the cost savings of all of the sustainable initiatives? And do you have an IRA or green funding team that is able to understand these programs and craft applications for the grants or these direct pay reimbursements? And if so, who builds those teams? Who's on those teams? Who should we be reaching out to?
So we don't have the team. Like I personally was very involved in applying for the IRA credits. It was kind of um, it was a learning experience for me. We did engage. We have KPMG as our tax preparer, and they're helping with, now that we've been approved to receive the credit, actually submitting the necessary documentation to get it. But they're just, they have an IRA kind of division at KPMG, but they're not specifically oriented around green finance. We worked with a different group. Kestrel did our green bond certification, but we don't know. I mean, it's we don't have a dedicated group doing it. It would be fantastic if we did. I think that Oakwell is going to develop more and more expertise in this, and that's one of their goals. And so I will hopefully in the future be able to rely on them, since I already am interacting with consultants from Oakwell, and that will be a growing area of expertise. Yeah. Oh,
I knew I was going to get there by muting myself. Sorry. Have you tracked your savings
oh,
looking at
have we
your
tracked the
sustainable
savings?
initiatives?
Not all together. We have it sort of individually for projects. Don't think that we have a figure for everything because yeah, some of it it's hard because some of it gets mixed with uh some of it's cost avoidance, some of it is sort of investments from donors. So we've had, you know, philanthropy has been a key part of this. For example, the I mentioned the Brockton Behavioral Health Center relied on a generous donation from an outside anonymous source. Um, so I mean, would you consider that a savings? Because now we're going to reap savings, you know, from the operational efficiencies and not needing to draw power or heat from the grid. But it's, you know, we didn't put that initial cost in either. So I think we could do it. We haven't done it completely. But.
Yeah, I mean, I think the key thing about being able to show those numbers is, most people think of green innovations and sustainable innovations as an add-on cost, but we see so often when you look at the total cost of ownership, or even the upfront cost of installation, they're often cheaper, especially as solar has gotten cheaper and cheaper and cheaper. And I just think it's unfair when we're having discussions for people to add on like a green tax when we should really be thinking about green rebates
Yeah.
for getting these sustainable programs in our healthcare systems.
Yeah, and that's why the green bond concept is very appealing because it's a way to raise money because they're in high demand. The interest rates are better. I mean, it is still debt, but it's something to consider. And then I think there's also there's yeah, this is something that's an ongoing conversation in our world. But yes, making the business case, being able to project out that return on investment is the most critical thing you can have on in your toolbox.
Okay, well, we've gone over already, but I want to thank you so much for a really amazing presentation. I want to thank our audience for joining us today and hope that everyone will come back in November to join us for our next talk, featuring a talk about plastics and healthcare that's really going to speak to us all, I think, about what we're eating, drinking, and how we're dealing with the plastic environment we live in. So that's November 6th at 12 Mountain Time, with Dr. Hilary Ong from UCSF and Dr. Matt Campen from University of New Mexico. Thank you again, Dr. Anna Goldman, for an outstanding presentation today, and the audience for some great questions and participation.
Thanks so much for having me.